Welcome to TrulyFit, the online fitness marketplace connecting pros and clients through unique fitness business software.
Dr. Michael Young, thank you so much for joining the TrulyFit Podcast. Why don't you give my listeners and the audience a little background on what you've done in the medical industry and your credentials, and a little bit about the impetus to write your most recent book, The Illness of Medicine.
Well, thank you, Steve. I hail from the state of Indiana, and I went to undergraduate studies there at Indiana University, and then matriculated to Rush Medical College in Chicago, where I graduated from, and then continued my training in urological surgery, also in the Chicago area. I practiced in the private sector in the field of urology for 28 years, and I left clinical practice about 5 years ago as I became increasingly frustrated by the changes in the medical environment. I wanted to write about it. I wanted to be able to express openly and objectively about it and not have the constraints of dealing with hospital and corporate administrations at the time I was doing so. But along the way, I had an interest in innovation, and I have become faculty at the University of Illinois in Chicago, where I am the director of the Department of Urology, Innovation and Technology. I teach a course in medical device innovation to medical students, as well as act as a medical advisor for the Innovation Center, where we develop and design new surgical instruments and medical devices.
I'm going to give a quick summary of your book. I read it, I enjoyed it, and you tell me if I missed anything for the audience. Okay, so from my perspective, the layman, not the physician, your book uses really great anecdotes and stories and examples throughout your entirety of your career, basically even before your career, I would say, starting because your father was a physician. So starting from the outset of you growing up and understanding a little bit about the medical community all the way until your retirement. And it's all the things you saw in the healthcare system and the medical community and industry that you felt had issues. So that could be very targeted things like, hey, the processes in pre-op are off and we could make sure that these that will logistically work better, or it could be more things that are sort of umbrella issues like the pharmaceutical industry and insurance and things of this nature. You kind of work through this, but you don't try to give specific examples on how we can fix all this. It's more about telling the people like me, the patient, that, hey, all the problems that you face, we understand, and that we are also facing them, and that we all have to come together to solve these problems.
Well, we do, but I also feel that at the end of the book, I am suggesting solutions. Most of the book is spent describing problems because I don't feel most people are aware of what goes on behind those closed doors or on the other side of the table as I describe it. But much of the problem is related to money. It is the flow of money in healthcare, and the solutions, I feel, are our ability, our capability of grabbing back some of that control. And I think if we can at least have some say in the direction of that money, we will be able to improve, modify the course that our healthcare industry is headed. So it really comes down to, he who owns the gold makes the rules. Yeah. We have to gain control of that.
Yeah, and your exact quote for the book is, the central role of money in medicine must change. And that's a great line, and that is very true. But would you also say that prevention is another key to this, meaning that if we can prevent people from having to use the medical industry to the extent that we have now, that we're a little bit overwhelmed in the industry, that could maybe slow the process down so that we don't have physicians having to see 26 to 29 patients a day?
Sure. Absolutely, but we don't sell health in the United States. We sell disease. I don't see too many advertisements on television about what to do to stay healthy. I am more inclined to see something on television that is selling me a pill. It is selling me a remedy. It is selling me a treatment. But we know, for instance, in other countries where preventative health is more the agenda, we do see fewer emergency room visits. We do see fewer hospitalizations. Patients, for instance, with their diabetic issues are not going to have the wide flux of highs and lows if there is more of a prophylactic or preventative approach to health care. We just don't seem to have that in the U.S., and obviously there are many reasons for it, but one of them is our perspective of remedy of health issues as opposed to preventative health problems.
Can you walk my audience through what it all encompasses to go about the process of surgery, from the outset of the patient walking through that door, whether it's at a hospital or a center, to them actually getting into the surgical room, to them getting home, and all the issues that one may come about that is sort of unexpected in that process?
Well, it is a long process, and unfortunately for many patients, it is as if they're driving to a location without a map. And I say that because very few patients are actually articulate in the healthcare process. They are oftentimes presented with a health issue when they are, not prepared for it. It is coming on unexpectedly, say an injury or an accident. And so they are navigating a process where they are really dependent upon others to guide them and direct them, and that can be extremely challenging. It can be extremely frustrating, and certainly one that creates a fair amount of fear and distrust because they are without control. But if you take a person who, for instance, presents to their physician with a problem, they have a complaint, that physician and his or her affiliated, mid-levels or associates will work up that condition. Working up meaning a variety of lab tests, typically physical exams and imaging studies. Many people are used to an X-ray, but when you start talking about other advanced imaging such as MRI or CT, they become a little less clear what that entails. And these advanced studies are very expensive. They also require, in some cases, preparation. They may involve dietary changes or particular imaging augmenters such as a barium or perhaps intravenous administration of contrast. So planning has to be made for these studies. They are often done in an imaging center or in a hospital environment, and so the patient obviously has to navigate those conditions. Once a decision is made that an individual has the problem, oftentimes alternatives are discussed. Should that patient undergo a medical therapy in terms of a physical injury, say a musculoskeletal injury, due consideration needs to be made to non-intervention, perhaps simply managed by physical therapy, which can be extraordinarily effective. Alternative forms of therapy, I feel, should be addressed. There are many conditions that can be treated with non-standard treatment. I'm not necessarily advocating them. I'm simply stating that this should be brought out. We have seen marvelous results with acupuncture or other alternative forms of treatment. And then, of course, surgery remains, from my perspective as a surgeon, as the last alternative. Even though I am trained as a surgeon, I feel that it is the most invasive, and therefore it is the last thing I want to come to as a means to resolve that particular problem.
But do you believe most surgeons also feel that way, or is that unique to you?
Well, that's a very good question, Steve. To cut is not to cure. To cut is to cut.
Yeah.
And, there's an expression in life that if you give a monkey a hammer, he'll treat everything like a nail.
Yeah. Yeah.
And individuals in their particular field of interest will treat a particular problem accordingly. The medical person will treat it with medicine. The osteopath or perhaps the chiropractor will treat it by some form of manipulation, and the surgeon will treat it with an incision. Are they all right? No. Are they all wrong? No. I think perhaps many surgeons, to your point, will be more aggressive in that direction, not necessarily out of some nefarious attempt to do more surgery, other than that is the tool that they are trained to use. And so, yes, a surgeon will more likely operate. Whether or not that is being done, out of self-interest, I think is more likely not the case. It's simply this is the tool they have. But to your original question, should a patient be told that surgery is really the best means to resolve their particular problem? And obviously, the patient has to do their own due diligence. They need to understand the risks and benefits, and they need to explain to their provider what they do or do not understand. There is nothing more frustrating for a physician than to have a patient who is unaware of what can happen. We want an informed patient. I want that patient to go and read up and learn, to obtain a second opinion on whatever that particular problem is. Now, I have to add a caveat to that, which is patients often feel that they can go online today, they can go on the internet, and within a matter of minutes or hours, they can become experts. And no, they can't. They can learn the vocabulary, but they don't understand the meaning. I practiced urological surgery and dealt primarily with cancer problems, particularly of the prostate, for nearly 30 years, and a patient is not going to go online in an hour and come back and try to have a similar conversation with me on the same plane. Although they may feel they understand the words, they really don't understand the meaning. So it's important that a patient do their best to get educated, trying to become familiar with the problem, but don't try to outwit or outdo the physician. They're not the enemy. They're simply expressing what you need done, and they want you to understand the language. Once the informed discussion has been made, that the patient is satisfied that they have been explained what they're going to undergo and why, arrangements will be made, typically by the physician's office, through various secretarial staff to make arrangements for that patient. This will often include the need for the patient to be seen by their primary care physician ahead of time for preoperative clearance and evaluation to make sure that the patient is okay for surgery, that they have no underlying lung or heart or other metabolic conditions that may put them at undue risk during a surgical intervention. They will be informed to obtain perhaps additional x-rays that they may not have had before. The other imaging may have been for that particular problem, and now they're looking to get a chest x-ray, EKG, and blood work that will be necessary for anesthesia. Once that has been completed, the patient will be given instructions when and where to show up at the particular hospital or surgical center they'll be treated at. Oftentimes, the patient will have to not have any food or water for at least 8 to 12 hours before surgery, depending upon the type of procedure and the type of anesthesia. And oftentimes this is referred to as NPO, or nothing per oral, oftentimes starting at midnight the night before surgery. The patient will often have to be at the surgical center or the hospital for 1.5 to 2 hours before surgery. They will then be directed towards the either outpatient surgical area or a generalized surgical holding environment. They will then be greeted by hospital staff. They will often have to change their clothes into a simple gown. That in itself can make many people feel extremely vulnerable as they are lying on a gurney with nothing more than a few millimeter thick sheet or cloth gown over them. But there, in that environment, they will often then have an intravenous line placed into their hand or arm. More instructions will be discussed with the nursing or hospital personnel. In many cases, at least in private practice, I or another surgeon will come in and greet their patient and often go over the procedure again, this time obviously in a more modified or abridged version. Consent is obtained, which is basically giving the hospital and or the surgeon permission to do the surgery. The surgery is then performed. The patient is brought into the operating room where they are greeted by the hospital staff, the anesthesiologist, who I assume they will have met in that pre-op holding area, will also be there to induce anesthesia. Once a patient goes to sleep, it's interesting to note that time is no longer something that they are cognizant of. If you put a patient to sleep for 1 hour or 20 hours, they don't know the difference because it really is not sleep as we think of sleep. So a procedure is performed. The patient will then awaken in the post-anesthesia recovery room. Oftentimes at this point, the patient is somewhat disoriented. They may be in discomfort and will need to express that to the caregiver with them. And depending upon the particular procedure, the patient may or may not be discharged, and if so, they will be given follow-up instructions, both post-operative care as well as when they need to follow up and notify their physician. And if they're hospitalized, of course, that will be given to them. Depending upon, again, the type of anesthesia, whether it's general anesthesia or local anesthesia or some combination of the two, patients will typically be prescribed analgesia, pain medication, perhaps an antibiotic will be given, or other drugs will be given to the patient, and oftentimes detailed instructions are given to the do's and don'ts. One of the things that I think is most important is that patients understand that whether they are young and healthy and strong, independent, living alone, it really doesn't matter. They will need someone with them for the next 24 hours. They will need assistance. Always assume you will need more help because you don't know the intensity of the discomfort or your ability to get around or navigate your home or apartment wherever you live. So you should have someone with you to assist. You may need someone to help you get to the toilet. Getting on and off a toilet, which is something we all do every day and it's routine, is not so routine if an arm is in a sling or a leg is in a sling or, is in a cast. Lots of things change, and so you have to accommodate for that loss of independence post-operatively. And of course, the rehabilitation after that point is really dependent upon what was done. Again, was this an abdominal incision versus a extremity that had some form of orthoscopic or orthopedic intervention?
Yeah, I love that you mentioned having someone there by your side. I actually, I've been through 2 surgeries, both had their own complications. And after my first surgery, which was a double inguinal hernia surgery, laparoscopically done with the Da Vinci, for those who don't know what that is, basically they're poking 3 holes, one through your belly button, one about 4 to 6 inches to the right and to the left. They go in, they mesh you up, and you're good to go. But, it was funny. There was a gentleman who was 82 years old, someone who I had trained, and he used the same surgeon, had the same surgery. He was back in that weight room in 2 weeks. I wasn't back for 4 weeks. We all
Right.
heal differently. It doesn't matter who you are, how strong you are, how young you are, right? Our bodies all take to these things differently. And
Yes.
what I wish I knew and what I did afterwards is I wrote down the 5 most important things that I wish I would have known. Number 1 was have someone there with you, because I didn't. And basically, I'm a strong guy. I only weigh 170 pounds. I couldn't really move below that area. So below where the incision was down I was nervous to move. So I had to sort of shimmy up my bed and
Yes.
pick my own legs up as if I was paralyzed in order to get to the bathroom on my own. Number 2, which they never told me in advance, which I wish they would have, is I should have really been in a recliner, not in a bed. A recliner would have allowed, number 1, the gas to sort of like dissipate earlier. I had a lot of problems with that gas stayed in me and was sort of pushing up on my lungs and causing breathing issues. And number 2, it was harder to get up and down being flat in a bed instead of being in a recliner. Number 3, I had really bad constipation. They gave me stool softeners. They didn't mention to have something like Miralax on hand, which I had to get after the fact, right? So there's all these little things you wish they would
Yes.
prepare you in advance for, but because it's so routine to them, they don't always seem to mention that.
Yes, you're absolutely right. And often it is the little things. We're all prepared for the big things, but it is the little things, the nuances that we oftentimes take for granted that we need to do. And yes, one of the most important aspects post-operatively is, of course, pain management, the use of analgesics. Certainly we're using less opioids today than we have in the past, which have been notorious for causing gastrointestinal issues, particularly constipation. I would also make the point of need for early and frequent hydration. You don't realize how much you need to drink, and as you're lying down, the motivation to get up to urinate you don't want to do, and so you tend not to drink. But we are water-cooled engines, and we do need hydration. And so certainly having meals prepared ahead of time for a day or two, or at least having easy access to simple meals is so important in that post-operative recovery period.
Yeah, I'd also like to add one more thing you touched on in your book. There is either no correlation, certainly no causation, between how nice a physician is and how great they are at surgery. So it's on us to do our due diligence.
Yes.
Not only sit down with that surgeon, but it's not just about trusting them. It's probably about looking at the numbers and looking at the ratios. I had a finger surgery that went awry, and I trusted the surgeon. And after the fact, I found out there was about a 50% ratio of his successes or not, when it should have been closer to a 75%. That was on me, right? I should have done my due diligence in that case. I trusted the person rather than looking at the numbers, and I don't think that's common for the general population to do.
You're absolutely right. Many people, Steve, will go to a physician because they've been recommended by their primary care physician. Very few people walked into my office off the street. They were referred, and you are dependent upon that primary care physician's experiences with that individual. And really, it is not so much personality, but outcome that becomes so important. Now, I've heard of many surgeons who have very challenging or almost icy personalities. You're not going to them to become their friend. You're going to them for a technical service. If they are friendly and if you have a relationship that is absolutely wonderful. On the same token, I'm not saying you want to be treated by someone who is just a cold stone. There has to be a happy medium where you feel comfortable enough with that individual that you can make inquiries, you can call, and not feel intimidated. But you also do need to look at their track record and understand. I was the chairman of 2 medical centers in Chicago, and I can very clearly recall discussing with administration about 1 or 2 physicians during my tenure where they had enormous numbers, which looked terrific, but as you mentioned, their complication rate wasn't so good. And so you have to look at the numbers, you have to do your diligence and decide and compare. One of the problems that I think patients are faced with today, however, is due to various insurance plans, due to networks, due to HMOs.
Yeah.
They may be restricted as to who they can see within their plan. And you may be referred to Dr. X and want to see Dr. Y, but Dr. Y is not in your plan. And that creates a real problem.
Yeah. But I think there's a part of us psychologically, this sort of cognitive dissonance, for lack of a better term. If you can't go see, Surgeon X, you're going to convince yourself, Surgeon Y will be fine, because you don't want to tell yourself, I'm going into surgery with someone who might not be capable and qualified. But I do think it's good that we tell ourselves up front, just like all mechanics aren't even, and all personal trainers aren't even. Not, all surgeons don't have the same exact skill set, and this is something we may want to pay out of pocket for if it comes down to that.
Absolutely. But it's very interesting, Steve. There are ways in many insurance plans to navigate. You have to be your advocate, because the system will not. The system is extremely fragmented. It is much easier to simply direct patients and they will follow the path. But if something smells awry, you're not comfortable with who you've been referred to see, you don't like the method with which the referral process is going. Your primary refers you to a particular physician and they request, for instance, your laboratory, your medical records, and for some reason they never seem to get them despite it being sent multiple times. You have to question the efficiency of that office. And if it just doesn't smell right, you need to perhaps let your primary know and request another physician to see you. So don't feel that you are always glued to that person you are referred. You do have a say, and I do feel that patients do need to speak up when things just don't appear to be consistent with their expectations.
That's a great point. And I would just add, being on my side of the aisle, me being the patient and you being the physician, it is a strategic two-way communication, because what you don't want to do as the patient is be so pushy and say, hey, I researched this is what I want. And although that doctor disagrees with you, he can sense that you're going to fight him every step of the way, he or she. So then they just write you whatever you want, whether it's the prescription or the referral to X, Y, and Z person. Although they have an experience that was bad with that person, they just know that they're not going to be able to talk you out of it.
Yeah, and that is one of the problems we see with direct consumer advertising. I believe it's in 2016, a study was done that showed over 700,000 ads on television that year for drugs. The United States and New Zealand are the only two countries in the world that allow direct consumer advertising of medical treatment, pharmaceuticals. And that puts everybody in a bind, because the patient sees the advertisement and it seems to work. So the patient goes to the doctor's office and is inquiring about that particular drug. And I just have to warn patients that the ads will tell you what you need. They'll tell you why you need it. But what they won't tell you is if you need it. And you have to rely on your physician to be able to make the distinction between the use and need for that particular drug and another treatment. So patients come to the office armed, ready. They want this drug. They want the little blue pill, right? It may not be the right pill, or they want the purple pill. That may not be the right pill, but they have it in their mindset already that that's what they need. And so be mindful of your physician's experience and expertise, and realize that the commercials that you're being presented, they're not directed towards you. They're made in general, and they're designed to sell a drug, not necessarily the appropriate drug for you.
As fitness professionals, we have to look over what's called a health history form before we work with our clients. And on that health history form, they obviously have to list their medications, because we need to know if there's any complications that may arise from any of these particular medications when we're exercising. And what I've seen over my years, I've over 30,000 hours experience working with people, is that it's rare that you see someone on one medication. They're usually on 0 or they're on multiple, right? Because you've now made the decision that this medication is going to fix this problem. So the next problem, this medication is going to fix this problem. And then you get down this bad road where you believe the medication is going to fix all the problems. But this leads into the next question I have, though, because it is difficult. Someone like my wife, she's a pediatrician, and people come into her office, let's go ahead and say they have ADHD or depression. It's much easier for her to deal with this in a pharmacological way than to get them into, let's say, a counselor or a psychiatrist, because those people are booked out for 6 months. So this is a whole industry problem. Am I right?
It is. We as Americans, though, typically want the quick fix, not necessarily the best fix. Well, we want the best, but we want it now. We want it yesterday.
Sure.
And the psychological intervention or even physical therapy, these are not quick fixes. They take months, 6 months, a year, 2 years to improve, and that's typically not the mindset of most Americans. To your point, though, about drugs, I would also caution that I have seen, patients come to the office with 10, 12, 14 drugs on their list. I would start thinking about trying to subtract drugs rather than adding, because many of these drugs interact. Patients who are taking one thing for one problem may be leading to another. And then rather than prescribing something to take care of that other problem, let's try to get rid of that original medication. And so subtraction is probably just as effective as addition when it comes to some of these issues. But again, it all goes back to the fact that the patient needs to be an advocate for themselves. They have to be willing, not obnoxiously, but openly question what's being done and ask the question, why? Why are you doing this? Why are you suggesting that particular treatment? Not as a affront to the physician or the provider, but really to make yourself a more informed and therefore probably a better patient.
Yeah, that makes a lot of sense. And I know what my wife sometimes struggles with is that she has to make sure that she lets the parents know that although she's willing to do X, Y, or Z, that is not what she would do in that circumstance, right? Because ultimately, if these parents are going to push back, it's different when it's one-on-one. When you're dealing with a parent and a child, that's a whole nother set of issues you have to deal with. But that this is not my recommendation. I'm willing to try yours, but ultimately, this is not what I would do. And hopefully, they come around at some point and say, well, this is the expert. This is the person who spent their life studying this stuff. Maybe I should, go their route instead of try mine.
Yes, agreed. The physician is not God, but they may have a tremendous amount of experience with a particular problem, and you have to heed that. That's why you're going to them.
So in your book, you write and you cover that, I guess you would call them the upcoming crop of medical professionals. Sometimes, and I think this is, if you're, I consider myself a dinosaur in my industry only because personal trainers typically don't exist after 45, right? I'm 37. It's just not a career you do your whole life because it's hard to make sure that your body's able and capable to do these movements. We usually move into something else. But, when we see this young crop coming up, we're able to point out what may be missing, what may have changed throughout time, where maybe they're not putting the effort in, maybe the job itself has changed, the hours have changed, the dynamics have changed. What do you see that has changed that you would like to potentially fix from the upcoming crop of medical professionals?
Well, that's a wonderful question, and I think a lot of it is a reflective of our current perspective of health care. Health care has become very roboticized. You have a protocol for treating X, Y, and Z, and our training is very much of this type of mentality, imaging, lab work, and maybe we'll do a physical exam. I'm finding that the younger generation has less experience with putting their hand on a patient, less experience with the need to hold hand, be a human. Now, part of that is due to the quota system, the mechanics of how offices and the corporate structure that owns practices today are demanding a much quicker, a much more a less friendly evaluation and a more goal-oriented evaluation. The days of going in to see the physician and he or she asking about the family is a rare finding today.
Yeah.
You're going in quickly, they're seeing you quickly. Oftentimes that physician is not even looking at you. Their back is to you as they are typing into the computer, in the electronic health code record about their exam. And so what I think is missing, to your question, Steve, is without getting too extreme, but I wish we could see a return to some of the humanity of what healthcare is about, and less of this business aspect of what it has become.
I like that answer, because you're not blaming it on the person. You're saying because of the insurance, because of the quota situations, because of how the EMR is and how much you have to write up in each individual patient, and because of all of these things, I can't walk into the office and walk into the room and say, "How are you doing?" And you go, "Hey, I have depression, I have a sprained ankle, and I think I might have a rash." They go, "I'll see one of those. You come back next week for the other two," right?
Correct.
So,
yes.
They just don't have that time.
Well, there's many factors involved, but we do know, for instance, that patients, when they know they have an upcoming physician's appointment, will have, they'll have prepared a list in their head, if not written down, of questions and problems. And we know, unfortunately, that in that initial statement by the patient, 77% of the time it's interrupted by the provider, and it's interrupted by the provider 18 seconds into the discussion. So it just shows you that provider does not have the patience, right, or the time to be able to listen to that which is so important to the patient. And I think this is tragic. I think, many providers are compensated now in a situation that they don't own their own practices. We know that, for instance, 70% of physicians less than 40 are employed by some corporate or hospital structure. So they are dictating to them, you have to see X number of patients per hour, per day, per week, per month, what have you. Well, that's not going to happen by asking about how's the family. And again, I think we need to get back to this. I think I'm not trying to be Pollyannish in my perspective. I'm not trying to be, down on the farm perspective of, the good old boys and how's everybody back home. But you do need some form of dialogue and communication with your physician, and I wish we could see that come back. So that is what I think is a problem today with our roboticized protocols of efficiency as medicine has become a transactional commodity to sustain the business of medicine.
And I don't know the numbers, but what I see anecdotally coming from this is now a lot of younger physicians, and I obviously want your take on this, are saying, I'm not going to work full time. This is crazy. I can't walk into the office and see 30 patients in a day, not have the time to give them, and feel like I'm not doing the proper service for each patient. So you know what? I can handle it for 20 hours a week. I'm just going to work 20 hours a week. And people are filling practices with NPs and PAs, and they're most physicians in the, let's say, the general pediatrics or the family medicine are not working full time anymore. Do you feel like this is happening? Is this going to be bad for the industry moving forward?
I think it is. I think that, well, we know statistically that 30 to 50% of physicians are experiencing burnout. Burnout being defined as physical or emotional exhaustion. I think if you have a physician who is in his or her office and they are just being forced to see patient after patient without time to digest, to be a human yourself, yes, you're going to become physically and mentally worn out, and therefore you're going to need more time off and retire earlier. I don't think this bodes well for the profession. It is a trend we are seeing, but again, when we have a corporate structure that owns the practice, we're seeing less individual responsibility. at 3 o'clock, I'm done. You have a problem, you can call so-and-so. Well, that is unfortunately not one that raises confidence in the patient's perspective of commitment by that physician. It causes a loss of continuity of understanding of care. If you look at the hospital environment today as a very good example, as more and more corporate structures have taken ownership of practices in hospitals, it became very apparent that it was very cost inefficient for physicians to go to the office, go to the hospital, make rounds and come back, or go to the hospital for an hour or two and make rounds. Better to have their own paid employee or hospitalist, which manages the physician's patients that are in the hospital. They can therefore stay in the office and churn out more patients more efficiently in terms of not necessarily quality of care, but simply monetary proficiency. So when you're in the hospital, you're going to be seen by this hospitalist, this individual who may be very well trained. I have nothing against them as physicians, but the perspective is you as a patient who have needed your physician or relied upon your physician for perhaps months or years, suddenly you're sick. And what you need now more than ever is that healthy or strong relationship with that physician. You need that face you're familiar with. Instead, you're confronted with a stranger who doesn't know you, who doesn't know details about you other than the immediate problem. And so when you're sick, when you're in need, when you've had that heart attack, the person walking in is looking at a clipboard, you're patient number 302 for the day, right? Again, it's become one of hand-off and roboticized treatment that I really don't feel bodes well for the profession. And understand, as I mentioned at the outset, we are all patients. I don't know any physician who is excluded from needing health care. We've all been in a dental chair. We've all had injuries. We've all needed stitches for something, and it's scary. And we need that face that we're familiar with. And as you stated, this working a shorter week because of burnout, because of all these other financial issues that are been described, I think it becomes an industry more predicated on efficiency than that of healing, which is what we went into it to begin with for.
You see a lot in schools, whether that is charter schools or just different types of schools that are coming out, where people will go on these ventures to back a new way to see what could potentially work, right? Whether that is economists mixed with sociologists, and they'll start these new ventures and say, you know what, maybe we can perfect the schooling process a little bit better. Let's go about it this way and see what we can do. Do you think that'll ever happen in the medical industry? Has that happened? Has somebody said, you know what, we're gonna start from the ground level. We're going to start from scratch and try to redevelop the system?
Well, I think it's a hopeful goal, Steve. I feel that if we're going to get there, it's going to be a generational change. We're talking 20, 30 years. The curriculums of the medical school, again, as I am now faculty at the University of Illinois and very much engaged with the students, I have seen and witnessed a change. We're putting the students through a rigorous academic environment. I hope we can find a means to include training exposure to humanness, if that is such a word, as opposed to simply technical, detailed information about a physiological process gone awry. At the end of the day, we're taking care of people. And if you can treat a person's emotions, if you can treat their anxiety, if you can give them confidence, I think you're going to improve their physical well-being in a much more effective manner.
Dr. Young, this has been great information. Where can my audience find more about you personally, more about your book, The Illness of Medicine? I know you've wrote a second book. Anywhere they can find your books and anything about you personally.
Well, thank you for asking. The Illness of Medicine was a non-fictional description of experiences in clinical practice. It can be found on my website, which is michaeljyoungmd.com. And from that website, one can find a link to either Amazon or to my publisher, GM Books. Or, of course, one could go to Amazon or any number of the e-book opportunities. In Chicago, where I reside, unfortunately, I think there are just a handful of bookstores. It's very hard to go to a bookstore today. They're rare, and just dealing with the cumbersomeness of parking and paying, and so I find many people are buying books online, and so obviously Amazon is an easy venue to do that, or simply through my website.
And I just want to add, we did not go over everything in the book. There's still a ton that we didn't talk about here, so it's well worth getting it and the read. My guest today has been Dr. Michael Young. Thank you so much for joining the TrulyFit Podcast.
Thank you so much, Steve.
Great.